Hello, everybody. Thank you for joining today's Neurocritical Care Society Journal Club. My name is Megan Barra, and I will be one of the moderators for today. I am joined by additional co-moderators, Dr. Muhammad Effendi from Capitol Hill Regional Medical Center and Abdallah Amar from Yale New Haven Hospital. Just for housekeeping, we will be incorporating Twitter engagement for this journal club with both the presenters and the moderators. You can follow along Twitter with the hashtag NCS Pharm, PHARMJC. It's my pleasure to introduce you to our first presenter for today. This is Dr. Elizabeth Schald from UF Health Jacksonville, and she will be presenting on Factor Xa inhibitor-related intracranial hemorrhage, results from a multi-center observational cohort receiving prothrombin complex concentrates.
Hello, everybody. Thank you so much for having me today. I just want to start by saying that I have nothing to disclose concerning any possible financial or personal relationships with the commercial entities that may be referred in this presentation. My institution did provide patients for this study. However, I was not involved in any way whatsoever in data collection or review of the manuscript, etc. The landscape of anticoagulation strategies has changed since the introduction of direct oral anticoagulants, or DOACs, about 2 decades ago. These agents have taken over and are now recommended over warfarin for the majority of indications due to the literature we have supporting their non-inferiority or superiority in efficacy and the lower risk of major bleeding, which includes intracranial hemorrhage. But there is still a risk of DOAC-related ICH. And of course, on clinicians' minds is how are we going to reverse this anticoagulation if and when the bleed occurs? As these agents gained popularity and the lack of a specific reversal agent remained, our prothrombin complex concentrate products became the reversal agents of choice based on results from animal models and studies on healthy volunteers. But prothrombin complex concentrates, or PCCs, are not labeled specifically for DOAC reversal. And in the fall of 2018, a new player came into the game, which was our coagulation factor Xa-ZHZO. This agent was initially approved by the FDA based on the drug effects on TNA levels in patients, and we're still lacking data comparing this agent to the longtime standard of care, PCCs. So let's start by taking a step back and take a quick look at how these products differ. 4-factor PCCs include products such as Kcentra and activated products such as FEBA, which provide coagulation factors 2, 7, 9, and 10, as well as the antithrombotic protein CNS. So although these products were initially created for the treatment of hemophilia, they've since been adopted for the reversal of vitamin K antagonists and more recently for DOACs. Our new reversal agent is coagulation factor 10A recombinant inactivated ZHZO, which for the simplification throughout the presentation, I will refer to as simply ZHZO. This product exerts its action by binding and sequestering factor 10A inhibitors, as well as binding and inhibiting tissue factor pathway inhibitor. To provide a better visual representation of these products, we have our coagulation cascade here. Our factor 10A inhibitors, such as apixaban and rivaroxaban, bind and inhibit factor 10A, thus inhibiting the conversion of prothrombin to thrombin, which would eventually prevent that fibrin plug formation. In the lighter orange boxes here, we have the 4 coagulation factors that our PCC products provide, with FEBA providing the activated versions of these factors. And lastly, we have ZHZO, which is represented by our 2 little Pac-Man figures. So at the top here, we have ZHZO binding to the 10A inhibitor, allowing for restoration of endogenous factor 10A activity. And then at the bottom, we have ZHZO binding and inhibiting the tissue factor pathway inhibitor, which is a double negative because we're removing the inhibitor, essentially increasing allowance of conversion from factor 7 to factor 7A. So with these small pieces of information about the effects of ZHZO and PCCs, how have the guidelines suggested that DOAC ICH be managed? Well, we can see here the approval of rivaroxaban in 2011 and apixaban in 2014. A few years later, in 2016, the Neurocritical Care Society and Society of Critical Care Medicine came out with a guideline for the reversal of antithrombotics in intracranial hemorrhage. suggesting the use of PCCs at that time, which was a conditional recommendation with a low quality of evidence. Just a couple years after that, in 2018, ZHZO was approved by the FDA under an accelerated approval pathway based on results from the ANNEXA-A and ANNEXA-R trials in healthy volunteers and interim results of the ANNEXA-4 trial. Interestingly, in the same year, 2 organizations published guidelines that included recommendations that mentioned the use of ZHZO. So our CHEST guidelines for the antithrombotic therapy for atrial fibrillation suggested that a specific hemostatic agent should be used when available, which was merely a discussion in the guidelines, but not a graded recommendation. And then the American Society of Hematology also provided suggestions in their guidelines for the management of venous thromboembolism to use ZHZO in patients with life-threatening bleeding when available. This was a conditional recommendation based on very low certainty and the evidence about the drug's effects. In 2019, the full results of the ANNEXA-4 study were published, and then just this year in 2020, there were 2 more consensus statements. The American College of Emergency Physicians Anticoagulation Reversal Strategies in the Emergency Department setting recommendations advocated for the use of ZHZO as a Tier 1 agent in life-threatening bleeding, and this was an expert panel recommendation which wasn't graded. And in the American College of Cardiology Expert Consensus Decision Pathway on the Management of Bleeding in Patients on Oral Anticoagulation also advocated for the use of ZHZO over PCCs in life-threatening bleeds, which again was an expert consensus and not a graded recommendation. So many of these recommendations have been made from the few limited trials that we have that were used to support the FDA approval of ZHZO. But of course, it's also important to look at what our primary literature suggests about PCCs for the reversal of DOACs. Over the past several years, there have been numerous small observational trials evaluating PCCs for the reversal of oral anticoagulant-related major bleeding. These trials generally have reported on double-digit numbers of patients, so very small, and only a few of them have been specific to intracranial hemorrhage-related bleeding. Additionally, in these trials, there have been inconsistencies in the definitions for hemostatic efficacy. So looking at those few ICH-specific trials, as well as the subgroups of patients with ICH from the other trials, the reported hemostatic efficacy ranged anywhere from 60 to 93%, and thrombotic events ranged anywhere from 0 to 9%. So obviously those are very wide ranges, especially in efficacy. So clearly there's still some gaps in the literature. We still need trials with larger sample sizes, providing ICH-specific data. We need consistency in the evaluation of hemostatic efficacy. And lastly, we really need some comparison of our PCC products to our ZHZO product in this patient population, especially now with multiple guideline and expert consensus statements suggesting the use of ZHZO over PCCs. If your institution hasn't already added ZHZO to the formulary, I'm sure it's on everyone's radar. So all of this is to say that the trial we're discussing today really addresses, I think, these first 2 gaps in the literature. And I think they have plans to move forward with their data and address the 3rd gap listed here as well. This trial was a multi-center retrospective observational cohort, and it included 26 certified stroke centers. The purpose was to evaluate the safety and efficacy of PCCs for apixaban or rivaroxaban related ICH. In their publication, the authors state that this is actually an ongoing trial, as they're also collecting data on outcomes with the use of ZHZO. So this is essentially pre-planned interim analysis, only including patients treated with PCCs as they await more patients treated with ZHZO. Patients were included if they were at least 18 years old, experienced spontaneous or traumatic intracranial hemorrhage, took a dose of apixaban or rivaroxaban prior to admission that warranted the administration of PCC products, and if they received either an activated PCC or 4-factor PCC in hospital. Patients were excluded if they had hemorrhages associated with other anticoagulation agents or liver disease, if they had a lack of follow-up because of withdrawal of life-sustaining measures within 24 hours of admission, if they were enrolled in any prospective study investigating ZHZO, if they were pregnant, lactating, or prisoners. Of note, patients were excluded from the hemostatic efficacy analysis of this trial if they did not have at least one follow-up image of their brain within 24 hours of PCC administration. Data was collected primarily by pharmacists at each site. Those collecting data were provided video training by the coordinating site, which detailed the trial protocol as well as information about data entry. The timing of the last DOAC dose was unable to be collected due to inconsistencies in reporting from site to site. CTs and MRIs were reviewed by licensed providers from each site with specialty experience in either neurocritical care, neurology, or neurosurgery. And these providers recorded the hematoma measurements from these images. Those who recorded the hematoma size did not adjudicate the hemostatic efficacy outcomes. If patients had multiple hemorrhages, the primary hemorrhage was defined as the hemorrhage with the largest bleeding component. The percent change in hematoma size was measured within 24 hours of PCC administration, and this percent expansion was used to adjudicate the primary hemostatic efficacy outcome. Hemostasis was defined using the classification by Sorode and colleagues, which has been used in previous studies of ZHZO as well as PCCs. Excellent hemostasis was defined as an increase in hematoma size of 0 to 20%. Good hemostasis was defined as an increase in hematoma size from 20.1 to 35%, and poor hemostasis was defined as an increase in hematoma size of greater than 35%. The primary efficacy analysis examined the percent of patients with excellent or good hemostasis. Patients were included if they experienced an intracranial hemorrhage, subarachnoid hemorrhage, or subdural hemorrhage with at least one follow-up image. And this trial excluded primary epidural and any intraventricular hemorrhage due to a lack of clear criteria to assess hemostasis in these subtypes. The primary safety analysis examined thrombotic events during hospitalization, and this included deep vein thrombosis, pulmonary embolism, acute ischemic stroke, myocardial infarction, and any other documented thromboses, which were assessed through a review of progress notes in the patient charts. Secondary safety outcomes included infusion-related reactions and thrombotic events during predefined periods of time. And other reported outcomes included in-hospital mortality, as well as ICU and hospital length of stay. As far as statistics go, the majority of the data was descriptive in nature. The primary efficacy outcome of excellent or good hemostasis was a binomial distribution, and it was evaluated via the Jeffreys interval. And in-hospital mortality was compared for patients who experienced poor versus excellent or good hemostasis, and this was evaluated using a chi-square statistic. Selected baseline characteristics are listed here. The majority of patients were of white race, and admission Glasgow Coma Scale scores were high, with the median in the safety analysis being 14 and in the efficacy analysis being 15. There was a pretty even split between the use of apixaban and rivaroxaban. The majority of bleeds were intracerebral or subdural, and most patients received the 4-factor PCC product. A total of 433 patients met criteria for inclusion, and of these, 354 had good or excellent hemostasis, which was 81.8% of patients. Listed here is also the breakdown of hemostatic efficacy rating by the primary hemorrhage location. So you can see that the majority of patients in all subgroups were classified as having excellent hemostasis. For the safety analysis, 663 patients were included. Of these, there were 26 thrombotic events in 25 patients, which was a rate of thromboses of 3.8%. Of these patients, 8 received activated PCC products and 17 received 4-factor PCC products. Looking at the types of thromboses in the graph on the right, the majority of patients experienced deep vein thrombosis, followed by acute ischemic stroke, then myocardial infarction, and lastly, pulmonary embolism. The majority of these events occurred within 14 days of PCC administration. And there was only one documented infusion reaction, and that was to an activated PCC product. A total of 53 patients experienced in-hospital mortality, which was a rate of 12.2%. In-hospital mortality was more common in patients with poor versus excellent or good hemostasis. Here listed are the hospital and ICU lengths of stay. The numbers listed here are from the safety analysis, as this included all 663 patients. The graph to the right of your slide breaks down the hospital discharge disposition for the patients, which, as you can see, only about a quarter of the patients were actually discharged home, while the living survivors were either discharged to other nursing or rehab facilities or to hospice. The authors concluded that PCC administration after apixaban and rivaroxaban related ICH achieved an 81.8% rate of effective hemostasis with a 3.8% thrombosis rate, although we still need RCTs evaluating PCCs in patients with factor Xa inhibitor related ICH. For my assessment of the trial, there were several strengths. The questions the authors set out to answer are all very clinically relevant. So there's clearly a lack of high quality data surrounding this question of DOAC reversal in ICH. This was a multi-center trial, and it includes the largest number of patients than any other trial on this topic thus far. Additionally, their methods were very clear. It sounds like they did a really good job making sure that data collection was as consistent as possible, considering the fact that they had so many sites involved and were manually extracting data from the charts. And lastly, I thought it was a strength of the trial that they did not rely on coding or medical billing or claim data. They actually had medical professionals who were responsible for assessing the imaging as well as the progress notes, which lends to a more accurate assessment of the outcomes. With that being said, there were a few limitations to take into consideration. So this was a retrospective observational trial with no comparison to placebo. However, most would likely argue that it would be unethical to withhold treatment that has been considered the standard of care for decades. The baseline GCS scores were pretty high, and this might correlate with the smaller hematoma volumes reported in the trial. Patients with epidural and intraventricular hemorrhage were excluded from the trial, and there was a sound reason for excluding these patients. However, this limits the extrapolation of these results to these patient populations. And lastly, I just wanted to address the hemostatic efficacy definition. So the Sorode criteria were used, and this definition is aligned with the definition for effective hemostasis suggested and validated by the International Society of Thrombosis and Hemostasis. But nonetheless, this definition is essentially dichotomizing hematoma volume into categories. And really how clinically different is a 33% growth in hematoma volume versus a 36% growth in hematoma volume, for example, which would be the difference between poor and good hemostasis. So not to say that there is necessarily a better way to assess hemostatic efficacy in this patient population, but just that we have to be mindful that the outcome of excellent or good hemostasis is based on these certain percentage cutoffs. In conclusion, as I mentioned previously, I think this is a really difficult concept to study because yes, we're interested in patient outcomes such as survival, of course, but the question here is really what agent should we be using to reverse DOAC-related ICH? And to assess that, we may need to use some of these surrogate outcomes such as percent change in hematoma volume. I think this trial mimics real-world scenarios where we might get patients in the emergency department that we can't assess when the last time they last took their DOAC was, and the decision needs to be made whether or not we're going to give a reversal agent. And based on all the background information we reviewed, this trial definitely adds a lot of information to the limited data we had previously on the use of PCCs for factor Xa reversal in ICH specifically. Overall, the results from this trial did demonstrate a high rate of hemostasis and a low rate of thrombosis. So not to compare apples to oranges here, but just as a marker of comparison, trials looking at PCCs for reversal of vitamin K antagonist bleeding, for example, also showed hemostasis in about the 70 to 80% range. And we accept that as a standard of care for vitamin K antagonist reversal. And in ANEXA-4, that trial reported 82% of patients achieving excellent or good hemostasis. And for our safety outcomes, the rate of thrombosis was actually lower in this trial than the 10% rate reported in ANEXA-4. So although these aren't direct comparisons, just keeping in mind these percentages, they're all kind of in the same ballpark for efficacy and safety when we don't have direct comparisons at this time. Lastly, as mentioned previously, another gap in the literature is that a large trial evaluating clinical outcomes in patients with HZO. And these authors are also currently collecting data on this topic as well. So if and when our colleagues start questioning whether or not PCCs are adequate for reversal of factor Xa inhibitors and start reevaluating our formulary for addition of ZHZO, I really think this trial provides the medical community with more confidence in utilizing PCCs for the reversal of apixaban and rivaroxaban related bleeding for both safety and efficacy. And I'm certainly looking forward to the second half of this analysis to see how the clinical outcomes of ZHZO will compare. Thank you so much for your time and attention, and I would be happy to take any questions at this time.
Thanks so much, Dr. Scheld. That was a great review of the study. For the audience on the call, do you think you could speak a little bit to your institution's practice for DOAC reversal and which therapy you currently prefer in dosing strategies?
So at our institution, we actually do not have ZHZO on our formulary or even as a non-formulary item. So the only product that we currently use is PCCs. So in these patients with major bleeding such as ICH, we would use PCC products. And then I think the second half was the dosing, and for that we would use 50 units per kilogram.
Thank you. And then my second follow-up question is, do you think there is a role at all for andexanet alpha or inactivated factor ZHZO for reversal of DOAC therapy, or do you think that prothrombin complex concentrate should be considered first line?
At this time, I just think we really need a lot more information about ZHZO. With the trials that we have currently, we can see that there was some reversal in the TNA levels, as well as hemostasis with the ANEXA-4 trial. So I'm sure there is a place in therapy for ZHZO, but I just think we need a little bit more data to guide when the appropriate time to use that product versus PCCs would be.
Great. And then we have one more question that came up in the chat. What selection criteria do institutions have on whether to reverse or not? So has your institution established any criteria for who should even get reversal at all versus not?
To my knowledge, we don't necessarily have a specific guideline or a policy that restricts which patient should be receiving these products versus not receiving them. So more of a clinical judgment call.
Hi, Elizabeth. This is Mohammed. Thank you so much for the presentation. One question that I had and kind of has been on my mind since the results of ANEXA-4 was the utility of collection of anti-factor Xa levels, which is obviously something that ANEXA-4 did, but I don't think that was looked into this study. Just what are your thoughts on the utility and the role of collecting anti-factor Xa levels for patients that are coming in with DOAC bleeds?
Yeah, so that's an interesting question as well. So since our factor 10A assays have to be standardized to specific products, there's kind of the question of whether or not from institution to institution. So for example, again, in our institution, we don't have our factor 10A assay standardized to our DOACs. We just have low molecular weight heparin as well as unfractionated heparin. And so when trying to compare that to the Annexa-4 trial, you know, I'm not sure if you could say that you could use the same cutoffs, for example, that they used in that trial of this 75 nanograms, I believe. So yeah, I think that's a limitation of using specific levels. And then of course, you know, using a lab value, kind of a surrogate marker again for outcomes that we're concerned about, which would be the hematoma growth or clinical outcomes for patients.
Thanks for that insight. I agree. I still think it's a bit of a question mark. And one big limitation is obviously institutions' ability to do the level in the first place, let alone have one that has such a rapid turnaround to affect decision making. So that'll be an interesting thing to keep following as we continue on this debate between these two drugs.
Great, thank you so much. If there's no more questions, we'll move on to our next speaker. So I'd like to introduce to you our next speaker, Dr. Christine Pham, and she will be presenting on the recent publication, the FAILS trial, ticagrelor added to aspirin in acute ischemic stroke or transischemic attack in prevention of disabling stroke, a randomized controlled trial.
Good afternoon, everyone. As stated, my name is Christine Pham. I'm a current PGY2 critical care pharmacy resident at the Philadelphia College of Pharmacy, University of the Sciences, in collaboration with Cooper University Hospital. And today I'm very excited to be able to share with you all ticagrelor added to aspirin in acute ischemic stroke or transient ischemic attack in prevention of disabling stroke, a randomized clinical trial that was published in JAMA Neurology on November 7th, 2020 by the FAILS investigators. Before I begin, I would just like to state that I have no actual or potential financial disclosures or conflicts of interest to reveal at this time. So the objectives for today will be to describe the role of antiplatelet therapy in patients who present with acute ischemic stroke or transient ischemic attack. We'll then examine the study design of a randomized controlled trial evaluating the effect of ticagrelor plus aspirin compared to aspirin alone in patients presenting with acute ischemic stroke or TIA. And then finally attempt to apply the findings of the study to current clinical practice while also placing consideration on its strengths and limitations. So to begin with some background, stroke is considered to be the leading cause of adult disability and death worldwide. Overall, it can be divided into two main subcategories, which are hemorrhagic and ischemic stroke. But 80% of cases of stroke are comprised of ischemic causes. Now, only 25% of patients with disability following ischemic stroke are found to improve by at least one modified Rankin scale point at 1 year, with no other significant improvement seen in the following 5 years. Risk of subsequent ischemic stroke is approximated to be about 5 to 10% within the first few months. And the reason that this number is so concerning is because the three main factors that may contribute to elevated disability following stroke is the severity of the initial episode of stroke, the patient's comorbidities, and recurrent episodes. So for that reason, one of the main objectives in reducing disability following stroke is really to prevent recurrence. Now on this next slide for you, I do have the modified Rankin scale listed. And essentially what this is a scoring tool used to define the severity of disability following stroke or another event that may lead to neurologic disability. Overall, the scale does range from 0 to 6, with 0 meaning no symptoms, 1 to 2 meaning no significant disability or slight disability, 3 to 4 is moderate to severe disability, 5 severe, and 6 death. So at this time, antiplatelet agents have been found to have a pivotal role in reducing the risk of subsequent stroke following an acute ischemic stroke or TIA by interfering with thrombus formation of platelets in disease and damaged blood vessels. So the main three agents that we typically use in this setting are aspirin, clopidogrel, and now also ticagrelor. So starting with aspirin, it's an irreversible inhibitor of both COX-1 and 2, leading to inhibition of platelet aggregation. I do also have dosing of these three agents listed on the table here just for your reference. And another thing to know about aspirin is that it is metabolized through hepatic conjugation. Now moving on to clopidogrel, this agent acts as an irreversible P2Y12 inhibitor, ultimately leading to prevention of platelet aggregation. And what's particularly unique about clopidogrel is that it actually acts as a prodrug, so its activity is dependent on the efficacy of CYP2C19 in order to convert clopidogrel into its active form. And then finally, we have ticagrelor listed here for you. And similar to clopidogrel, it is a P2Y12 inhibitor, but this agent is actually a reversible inhibitor and is metabolized hepatically via CYP3A4. So unlike clopidogrel, this agent is not a prodrug. So at this time, the American Heart Association and American Stroke Association does have 2019 guideline recommendations for the role of antiplatelet therapy in preventing recurrent stroke. So starting with aspirin, at this time, it's recommended to administer aspirin within 24 to 48 hours after onset of an acute ischemic stroke. Furthermore, in patients with minor non-cardioembolic ischemic stroke, which is defined using an NIHSS of less than or equal to 3, dual antiplatelet therapy with both aspirin and clopidogrel is recommended to be initiated within 24 hours of symptom onset and continued for a minimum of 21 days or up to a maximum of 90 days. Now, of note for both of these recommendations, they're considered a level 1 class of recommendation, meaning that is a strong recommendation that is based on level A evidence, meaning high quality evidence. Alternatively, however, for ticagrelor at this time, it is not recommended over aspirin for treatment of patients with minor acute strokes. And this is based on a class of recommendation 3, meaning no benefit has been shown with ticagrelor compared to aspirin. And the level of evidence for this is based off of moderate quality evidence using randomized controlled trials. So with that said, I do want to take the next few minutes just to go over a couple of the trials that led to these recommendations. So starting with the CHANCE and the POINT trials, these were the two pivotal trials that led to the approval of clopidogrel plus aspirin as dual antiplatelet therapy in the setting of ischemic stroke. So in 2013, the CHANCE trial was published by the New England Journal of Medicine, and it was a randomized double-blind placebo-controlled trial that evaluated the use of aspirin alone compared to aspirin plus clopidogrel. 5,170 patients were included and randomized within 24 hours after onset of a minor acute ischemic stroke or high-risk TIA. The primary endpoint in the study was stroke at 90 days, and what researchers did find was that there was a significant reduction in the rates of stroke by 90 days with administration of aspirin plus clopidogrel. And interestingly, this was associated with a number needed to treat of only 29 patients. Furthermore, when looking at safety, researchers found no significant difference in rates of bleeding with either treatment regimen. However, this study did experience some scrutiny due to the fact that it was conducted in a majority of a Chinese population, so it limited extrapolability to other populations outside of this. So for that reason, in 2018, the POINT trial was published again in the New England Journal of Medicine, and this was another randomized double-blind placebo-controlled trial that evaluated use of aspirin alone compared to aspirin plus clopidogrel. This study included 4,881 patients who were randomized within 12 hours after onset of a minor acute ischemic stroke or high-risk TIA. The primary endpoint for this study was major ischemic stroke, myocardial infarction, or death due to an ischemic cause at 90 days. And again, researchers were able to show that there was a significant reduction in the rates of primary endpoint with administration of aspirin plus clopidogrel, this time associated with a number needed to treat of 67. However, for safety, they also showed that there was a significant increase in rates of major hemorrhage with administration of both aspirin plus clopidogrel compared to aspirin alone. Now for the next two trials I'll go over, these focus more on the use of ticagrelor in the setting of stroke. So starting with the Socrates study in 2016, this was a randomized double-blind placebo-controlled trial, and this time it looked at aspirin alone compared to ticagrelor alone. This study included 13,199 patients who were randomized within 24 hours after onset of stroke, and the primary endpoint here was stroke, myocardial infarction, or death by 90 days. And interestingly, researchers did not see a significant difference in the rates of primary endpoint with either aspirin or ticagrelor administration. Additionally, there was also no significant difference in rates of major bleeding with either regimen. And then now most recently, that brings us to our most recent trial, which was published in July of this year in the New England Journal of Medicine, the THALES trial. This was another randomized double-blind parallel group placebo-controlled trial that this time looked at aspirin alone compared to aspirin plus ticagrelor. 11,016 patients were included in the study and randomized within 24 hours after onset of a mild to moderate acute ischemic stroke or high-risk TIA. The primary endpoint here was incidence of stroke or death at day 30, and researchers again were able to show that there was in fact a significant reduction in rates of the primary endpoint with administration of aspirin plus ticagrelor, and that was associated with a number needed to treat of 92. However, again, researchers showed that for safety, there was also a significant increase in rates of severe bleeding with administration of aspirin plus ticagrelor compared to placebo alone. Now, another thing that I would like to point out about the THALES trial was with one of its secondary outcomes, which looked at overall disability. And interestingly enough, while researchers were able to show a significant reduction in stroke or death, they were unable to show a significant difference between each regimen in rates of overall disability by 30 days. So for that reason, that brings us to our primary focus for today, which is ticagrelor added to aspirin in acute ischemic stroke or transient ischemic attack in prevention of disabling stroke. This was published in JAMA Neurology on November 7th, again by the THALES investigators. So this was an exploratory analysis of the original THALES trial that sought to evaluate the superiority of ticagrelor plus aspirin compared to aspirin alone, this time in the prevention of specifically disabling stroke. And they also sought to understand the factors associated with recurrent disabling stroke. So as mentioned earlier, this was a randomized, double-blind, placebo-controlled, multi-center international parallel group study. It was conducted in a total of 414 sites in 28 different countries, and enrollment took place from January 22nd, 2018 to October 7th, 2019. The study was also funded by AstraZeneca. So for patient population in this study, anyone greater than or equal to the age of 40 years old was included, and they had to be randomized within 24 hours after symptom onset with either non-cardioembolic acute ischemic stroke with NIHSS scores less than or equal to 5, or a high-risk TIA, and that was defined with an ABCD stroke risk score greater than or equal to 6, or ipsilateral atherosclerotic stenosis greater than or equal to 50%. For exclusion criteria, anybody with a history of atrial fibrillation, ventricular aneurysm, or another suspected cause for cardioembolic TIA or stroke were excluded, in addition to anybody with administration of IV or intraarterial thrombolytics or mechanical thrombectomy within 24 hours prior to randomization, any known coagulation disorder, or history of symptomatic non-traumatic intracerebral hemorrhage, GI bleeding in the last 6 months, or major surgery within the past 30 days. For interventions in this study, the patients were randomized 1-to-1 to receive either ticagrelor plus aspirin compared to placebo plus aspirin. So for patients who were placed into the ticagrelor group, they were initiated on a loading dose of 180 milligrams, which was followed by a maintenance dose of 90 milligrams every 12 hours. And then all patients that were included in the study were started with aspirin with a dose of 300 to 325 milligrams, and then continued at a maintenance dose of 75 to 100 milligrams daily. So for either of these interventions, they were continued for a total of 30 days, after which the patients were able to be treated with standard of care. However, that care was solely at the discretion of the investigator. Follow-up visits in the study were also planned to occur at day 7, 30, and 60, whereas for day 7 and 60, those visits could be telephone call visits. So for the endpoints of the study, starting with the primary outcome, researchers looked for first subsequent event of stroke or death. And the secondary outcomes included the first subsequent ischemic stroke, as well as overall disability by day 30. And overall disability was defined using an MRS score greater than 1. For the safety objectives, researchers looked at the first severe bleeding event, as well as the first moderate to severe bleeding event, and the first intracranial hemorrhage or fatal bleeding event. They also collected data on the occurrence of premature permanent discontinuation of therapy due to bleeding and due to an adverse event, and occurrence of severe adverse events. For statistical analysis of this study, efficacy and safety were both analyzed using an intention to treat principle. And then assuming a hazard ratio of 0.775 in favor of ticagrelor, researchers determined that in order to achieve 90% power with an alpha of 0.05, a total of 647 primary endpoint events were needed. So using the data from the Socrates study, they found that by day 30, 6.7% of patients had a primary endpoint event. So they approximated that in total, in order to achieve 647 primary endpoint events in this study, they would need 11,000 patients to be enrolled. So primary endpoint was evaluated using Cox proportional hazards model, and then explanatory variables that were included were treatment group, history of stroke, as well as the baseline NIHSS score. So in total for enrollment, a total of 11,016 patients were randomized into the study, with 5,523 patients in the ticagrelor group and 5,493 patients in the placebo group. Overall, over 99% of patients in both arms did receive at least one dose of their designated study drug. And then for those specifically in the ticagrelor group, 284 of those patients did experience subsequent stroke, with 272 patients having a 30-day MRS available. Alternatively, in the placebo group, 347 patients did experience subsequent stroke, with 30-day MRS available for 332 of those patients. So baseline characteristics here are listed for you on the next two slides, and they're divided based on patients on the left with MRS 0 to 1 at day 30, and that I'll refer to as patients with non-disabling recurrent stroke. And then on the right, it's patients with MRS greater than 1, which I'll refer to as disabling stroke. Overall, based on what was reported in the original Thales trial in the New England Journal of Medicine, for ticagrelor and placebo, there was no significant difference in the baseline characteristics between these two groups. However, there are several things that I would like to note about the study. Starting with race and ethnicity, an overwhelming majority of the patients who were included in the study were of white or Asian background. And then to add on to that, patients of Black or African American background or who had a reported race as other were significantly underrepresented in the study. Additionally, if you look at the region that the study was included, only 0.2% of the patients were from North America. So specifically for most of the people that are watching today who practice in the United States, it'll make it difficult to extrapolate these results to our own population. And then the final thing to note is for hours to randomization, over half of the patients were randomized greater than or equal to 12 hours after symptom onset. Now moving on to other characteristics such as past medical history, dyslipidemia, diabetes mellitus, and previous ischemic stroke did appear to be slightly higher in both the ticagrelor and the placebo group, specifically in patients who did experience disabling stroke by day 30. For a qualifying event, one interesting finding was also that an overwhelming majority of patients did present initially with ischemic stroke. So TIA was actually an underrepresented population in this study. Now, of those patients who did experience ischemic stroke as their qualifying event, for the patients that had a non-disabling ischemic stroke, a majority of them did have baseline NIHSS scores of less than or equal to 3. And that's interesting when you compare it to those who experienced disabling stroke, where there was an even amount of patients in both ticagrelor and placebo groups that had baseline scores of less than or equal to 3 and greater than 3. So at that point, that brings us to the results of the study. So starting with its efficacy outcomes, the primary outcome, again, was incidence of stroke or death. So the researchers did divide this based on patients who experience non-disabling stroke and disabling stroke. And what was an interesting finding is when you look specifically at those with non-disabling stroke, there was no significant difference in the rates of the primary outcome between ticagrelor and placebo. However, when you take a look at those only with disabling stroke, patients who were randomized with ticagrelor had a significant reduction in rates of incidence of stroke or death. Furthermore, that data kind of repeats itself when you look specifically at stroke, where again, you only see a significant reduction in rates of stroke in patients randomized to ticagrelor that had disabling recurrent stroke by day 30. And then finally, again, you see the same type of results with ischemic stroke, whereas there was no significant difference in patients with non-disabling stroke. Moving on to the safety outcomes of the study, again, with severe bleeding for non-disabling stroke, there was no significant difference between ticagrelor and placebo, but in those that did experience disabling stroke by day 30, there was a significant increase in the rates of severe bleeding with ticagrelor administration. Those results are also repeated when you look at intracranial hemorrhage or fatal bleeding, where again, there was a significant increase in these rates with ticagrelor administration only in those patients that had disabling stroke by day 30, but no significant difference in patients that had non-disabling stroke. And then finally, last thing to note about the safety outcomes here was premature discontinuation of drug due to bleeding. And in both patients who experienced disabling and non-disabling stroke, so we find that there was a significant increase in rates of discontinuation with ticagrelor administration. However, one thing to note with the overall safety outcome was despite these differences, in total, there was not a significant incidence of severe bleeding or adverse events with ticagrelor administration overall. So the researchers in this study also took it a step further and sought to look for independent predictors of recurrent disabling stroke. And what they found was that those who had presented with an index event of ischemic stroke with their baseline NIHSS greater than 3 was associated with an increased risk of recurrent disabling stroke or death, as well as patients with ipsilateral stenosis greater than or equal to 30%, patients of Asian race, older age, higher systolic blood pressures, and past medical history of diabetes mellitus. On the other hand, they found that dyslipidemia and randomization to ticagrelor was actually associated with a decreased risk of recurrent disabling stroke. So ultimately, what authors did conclude in the study was that in those presenting with mild to moderate ischemic stroke or high-risk TIA, compared to patients who received aspirin alone, administration of ticagrelor did result in a clinically meaningful relative risk reduction of disabling stroke and death, and that was associated with the number needed to treat of 133 patients. Additionally, they also found a significant reduction in the total burden of disability due to recurrent ischemic stroke at day 30. And that was associated with a number needed to treat of 112 patients in order to prevent one episode of recurrent disabling or fatal ischemic stroke. So at this time, just to quickly evaluate the study, starting with its strengths, this was a relatively large study, including over 11,000 patients, took place in multiple countries and at multiple sites. It also utilized an intention to treat analysis, so all patients who were randomized initially were included in the primary outcome analysis. And then as stated earlier, baseline characteristics between the ticagrelor group and the placebo group were well matched. Also for endpoint, for follow-up, for primary endpoint, 99.8% of patients were available for follow-up, showing that almost 100% of patients were available at 60 days. And then the last thing to note is that a clinically relevant outcome measure was evaluated because in the study, they sought to look specifically at recurrent disabling stroke. However, that brings me to a couple limitations that I would like to point out with the study. And again, just to bring it up again with the generalizability of the study, it is really limited because only 0.2% of patients were from North America. So for how most of us practice, it may limit us applying the results to our population. And to add on to that, over 90% of the patients in the study were of white or Asian race. So again, makes it difficult to extrapolate the results to other populations. And then to add on to generalizability, another area to consider was that the study excluded patients who presented with more severe strokes. So for those presenting with NIHSS greater than 5, again, it makes it difficult to extrapolate the results of the study to that population. Another thing to note was that treatment following the 30-day treatment period was solely based at the discretion of the investigator. Now, while the primary endpoint events were only evaluated up until 30 days, so overall that may not really be affected, it could affect safety outcomes. And then another thing was that these differences in treatment were actually not reported in the study. And then the final thing that I would like to note in terms of the study was that it did evaluate a non-primary and a non-secondary outcome measure. So while the primary objective of looking at the efficacy of ticagrelor plus aspirin in patients with acute ischemic stroke for non-disabling recurrent stroke was a pre-specified explanatory objective that was in the original Thales protocol, it was not one of the primary or secondary outcomes that were listed. So it makes it more of an exploratory analysis and therefore really limits our ability to draw conclusive results from what was found in the study. So to really take it all back and apply it to our current clinical practice, I do believe that ticagrelor is a reasonable alternative for patients who specifically present with non-severe, non-cardioembolic acute ischemic stroke or TIA, in whom clopidogrel may not be an optimal therapeutic agent. However, again, just to bring up the generalizability, given the patient population that was included in the study, we can't really apply the results to those with more severe strokes, cardioembolic causes of stroke, treatment initiation beyond 24 hours, as well as the populations that may not have been well represented in the study. And then finally, if a patient is decided to be started on ticagrelor plus aspirin, the one thing that we must continue to keep in mind is benefit versus the increased risk for severe bleeding. So in the original Thales trial in the New England Journal of Medicine, they actually did report a number needed to harm of 263 patients. So in summary, dual antiplatelet therapy with ticagrelor plus aspirin in patients who present with acute ischemic stroke or TIA may lead to a reduction in the risk of recurrent disabling stroke. However, this now may bring up a new question of whether ticagrelor plus aspirin may be superior to clopidogrel plus aspirin or vice versa. And just because of the differences in the primary outcomes, as well as patient populations that were evaluated in the POINT, CHANCE, and the Thales trials, we are really unable to directly compare these results to really determine that answer. So that kind of brings me to my last point, is that future studies are really required to determine the superiority of one dual antiplatelet regimen over another in this setting. So with that, that is the end of my presentation. Thank you all for tuning in today, and I'll be happy to take any questions.
Thank you for your presentation. We have a couple questions in the chat, and I have some as well for you. The first question, why do you think there was a decrease in stroke without a subsequent difference in good outcomes defined as an MRF score of 0 to 1 in this trial?
Sorry, can you repeat the question?
Why do you think there was a decrease in stroke without a subsequent difference in the proportion of patients with a good outcome?
Specifically for the Thales trial, so for the New England Journal of Medicine Thales trial, one of the points that the primary investigator had actually brought up with that study was that there might have been too much background noise, which essentially I think they meant because they didn't look specifically at those with recurrent stroke. So there may have been more factors playing into the patient's baseline disabilities already, or in those who didn't experience a recurrent stroke.
Great. And then another question. So you mentioned a couple of times that the North American patient population is very underrepresented in this clinical trial with only 0.2% of patients in North America. Would you expect that the outcomes as it pertains to reduction in recurrent stroke or increase in bleeding is higher or lower in a North American patient population compared to that observed in this study?
I would think in America, we would have hopefully lower outcomes just because there wasn't a full list of all the countries that were involved, but I'm assuming just because we have improved healthcare, access to healthcare, we would ideally have improved outcomes in terms of outpatient management of these patients. Since the study had such a long follow-up, a lot of those factors played a role too. So I think that was a lot to consider with how they're treated once they're outside of the hospital.
Hi, Christine. It's Mohammed. Thank you for the presentation. It's really interesting. Do you think there's a role for testing of antiplatelet reactivity testing for patients on clopidogrel to maybe be that as a segue for the use of ticagrelor for these patients?
Yeah, that's a great question. And that's something I also considered myself. In my own practice, I've only seen testing maybe like a handful of times so far. So to really be able to apply it to all patients, kind of like with Elizabeth's presentation, that is an issue with accessibility. I think potentially if the hospital has the resources, that would be an option. But when you're considering the time frame as well, that the patients will be on the therapy for, it's only 21 days. So if it's like an issue where they're already started on clopidogrel and then the idea is to switch it over, I think one thing that might be considered is like how much longer of the treatment do they have if they're going to go beyond the 21 days to the 90 days. Or if it's a patient, for example, of Asian race who are particularly at higher risk for having the CYP2C19 mutation, those are patients that I may consider that in.
Great, thanks.
Awesome. So I think that's all the questions that we have today. Thank you to our two speakers for presenting. And we've had lively discussions in the chat as well as on Twitter, so please follow along. It will be continuing on throughout the day. Thank you, everybody.